Shall I start now, Himanshi? आप muted हो, you are muted. Please confirm.
Yes, yes, please start.
Okay. Good evening, everyone. Welcome to the second part of the 17th masterclass of Jaipur surgical tutorial, which is on corrosive esophageal injury. For those who are joining or who will be watching our master classes for the first time, this is an extension of Jaipur Surgical Tutorial, which is an online education portal which we started more than 3 years ago at the Mahatma Gandhi Medical College and Hospital, which is a part of the Mahatma Gandhi University of Medical Sciences and Technology. The Jaipur Surgical Tutorial is coordinated by my colleague, Dr. Anand Nagar, who is a professor of HPB surgery at my institution. In between the sessions, I will be projecting a slide which will give you information about as to how you can join Jaipur Surgical Tutorial. You just have to send a WhatsApp message to Dr. Anand. He will add you to the group, and then you will start receiving information about all the educational activities. So under the JST, we conduct a session every Saturday, 9 a.m. to 10 a.m. India time, where students present cases. They also present operative procedures and the faculty moderates, which is like a preparatory session for your exit exam. And then for last 1.5 years, we've been conducting these master classes, which are done last Wednesday and Thursday of the month, 7 p.m. to 9 p.m. both days, where we select a topic and then we gather a panel of experts for moderating and for presenting. And there is a half an hour open house session. After the session, in between, I would announce that how you can receive more information, more reading material on the topic, where I send complimentary soft copies of the chapters from my books related to this. So if you send me a mail at vkkapoor.india@gmail.com, write esophagus in the subject of the mail. So within a week, all the mails that I receive, I will send you the chapters on clinical surgery and operative surgery related to esophagus, which would cover both esophageal cancer and benign diseases, including corrosive injury. So for this topic, I have requested two of my colleagues, Dr. N.R. Dash, who's a professor of surgical gastroenterology at the All India Institute of Medical Sciences in New Delhi, and Dr. Vikas Gupta, who was earlier professor of surgical gastroenterology at the PGI Chandigarh, and who's currently in the National New Medical Center, Abu Dhabi in UAE to moderate the session. So with that brief introduction about JST and the master classes, I hand over to Dr. Dash and Dr. Vikas to moderate the session. Dash.
Good evening, sir. Good evening, Vikas. And good evening to all who are watching this or will be watching later on. So we had part one of the corrosive esophageal injuries. That is the acute injury part we discussed yesterday. So little bit touching upon what we discussed yesterday. I am presenting that one through few of the slides. See, in India, the Honorable Supreme Court has a very clear-cut directive regarding how you should sell these acids, sell these corrosives, and how you should purchase, how they should be handed over, stored, everything. And there are also constant educational efforts from the government as well as the social service organizations to educate the people regarding rather how not to misuse these things. But in spite of that, it is a sad state that we used to get plenty of cases here in our institute, and I know they are everywhere in India. It is a global problem, as Dr. Vikas has said. Just the red line corresponds to those areas which are sporadic with this problem. And in India, out of all the corrosive injuries, out of all the chemical injuries, be it poison, the poisonous snakes, rodenticides, etc., drugs, chemicals, the corrosives, in true sense, those alkalis and the acids, they constitute about 27% of the cases. And it is estimated that out of all the suicidal attempts, 28% of them are because of the corrosives. What are corrosive? Corrosives are chemicals causing tissue injuries on contact, and usually they do damage when they are in high concentrations. There's a pH less than 3 or alkali side more than 11. Caustic, you may hear these terms caustic and lye. Caustic, according to the dictionary, is any chemical substance that on contact causes injury to the tissues. Lye is mostly used in Western countries. These are strong chemicals of sodium hydroxide and its analogs. The mostly the what we are getting in India are acid injuries because of maybe easy availability, and we say that toilet cleaners are the commonest of all, but so the toilet cleaners are acidic, whereas the floor cleaners could be of the same company, could be alkali. So mostly these are 10% hydrochloric acid, sulfuric acid, phosphoric acids, which are ingested. And among the alkalis is that the drain cleaners, which are mostly used. We can get battery induced injuries for acids, also the alkaline batteries. See, the mechanism and the pathology all could be initiated by regeneration of the reactive oxygen species that's shown by the Turkish group in two of their publications. And this leads to thrombosis of the vessels, congestion, and necrosis, which can occur within seconds. Within first 3 days, these steps which are shown in blue color can happen. A scar formation in acid because of coagulation. There is a thick scar formation. A scar, we say, as we the same injuries. The pattern is same as we see in skin burns in our surgical practice. And then there occurs infection and inflammation, mostly bacterial inflammation, formation of the granulation tissue, ulceration and perforation. And then the reparative stage starts. The fibroblasts are laid down and repair continues up to 10 days. And over that, either epitheliation can occur or there could be further cicatrization or scarring. This mostly proceeds for about a month. The strictures can occur within weeks, mostly occurring within third month or fourth month, and they may continue to occur, progress up to 2 years, even more than that. We will discuss about the incidence of carcinoma today in the later part of our discussion. Now, for the students, it's a stock question that what is the difference between the acid injuries, alkaline injuries, but in actually clinical practice, the volume that is being taken from the acid sides and the alkali sides, ultimately the effects are more or less similar. It all boils down to what is the grade of the injury that is happening to these people. The acids coagulates the proteins. The alkali liquefies by damaging the proteins as well as the fats. Both produce heat. Alkali produces more heat, and acid forms a scar. Alkali causes thinning, so there's more chance of perforation and deeper injuries. The duodenum is involved more or less similarly, identically in both the cases. Acute complications are also could be comparable in both the injuries, and the mortality rate is usually 12%, 12 to 15% in both the groups. The outcome is usually poor if the injuries are associated with bleeding. If there is, we discussed about the endoscopic grading. If there is grade 0, 1 or 2A, there is almost no chance of formation of a stricture. As the grade becomes higher and higher, the chance of forming stricture becomes higher, and by the time we reach grade 3, it becomes 100%. There are factors which can affect the severity of the injury. The four common factors are the pH, the concentration, the volume present, and the duration of the contact. Acids, which are mostly available in solid crystal forms, they get stuck to the esophagus and cause more damage to the esophagus if they are in crystallized form. The duration is also important in, as Dr. Vikas had shown that in mouse models, it was shown that 22 point, if the alkali is 22.5%, if it touches for 10 seconds, there would be transmural necrosis. And if it is 30%, and even within a second, it can cause transmural necrosis. So these are the agent factors. Then the host factor would be if there is a full stomach, there is a chance of protection, versus if there is an empty stomach, there is initial pylospasm and the acid can remain there or the corrosive can remain there, causing more damage. The presence of GERD has been found quite significantly in these patients. It's about 20 to 30% of cases they have GERD, where we find the damage to the lower part of the esophagus or middle part of the esophagus is more. So 15% of these people are usually found to be asymptomatic. Of course, depends upon all these factors. And age, the total leukocyte count, and the grade of the injuries are prognostic factors in these patients. So little bit touching about the history. In 1910, there was first publication regarding this effect of these injuries in 4 cases. And since then, roughly, there are 2 lakh injuries reported per year all over the world. And 13.6% of these poisonings are fatal. Acid is the most common cause, and 47% of the deaths are due to perforation peritonitis. So in the pie diagram, which Vikas had shown, that the yellow part which is there shows the incidence on the left side, and on the right side shows the mortality. So it's a long, arduous, difficult, stressful journey for a corrosive patient. If he comes like this, and this is one of our cases, so the stomach completely burnt up, and then he recovers, he goes for dilatation, and then the further sequelae of this condition, and finally till he becomes fit. It's really a long journey. So yesterday we were somewhere here halfway stage. That's the acute part. We discussed the role of endoscopy, the endoscopic findings, when to intervene. Dr. Anupam said that there should be ideally a review endoscopy, because the initial endoscopy is actually not very informative, or may not be actually correct. And then he discussed more of what not to do. Those points were more important than what to do. There was no established role of EUS, endoscopic ultrasound, MRI, the PPIs, and use of sucralfate in these patients. So in case of suspicion of the fistula, the oral intake has been delayed. Even if there is a stent, role of a stent, which is exactly not very established, if at all stenting is to be done, it should be done through to the tracheal side rather than the esophagus side. And Dr. Vikas very elaborately discussed about the indications for surgery after corrosive injury, the procedures which are to be followed, their complications, and how to follow them up. So today, to take us further towards the sequelae, the complications, and till the end point of this condition, I would request Dr. Vikas to carry forward this discussion. Dr. Vikas, please.
Yeah, thank you, Dr. Dash. So I think yesterday we have elaborately discussed about the acute part of the injury. So now, I mean, endoscopy plays a very important role in determining and managing these patients after the acute insult is over. It helps in identifying the strictures, and many of the strictures can be managed endoscopically. And to discuss about the endoscopic management, I will request Dr. Anurag Govil, who is a gastroenterologist at Santokba Memorial Hospital at Jaipur, to speak on the endoscopic management of corrosive injury. Over to you, Dr. Anurag, please.
Yeah, thank you so much.
Before Dr. Anurag starts, let me add, Dr. Anurag is one of the senior most and most experienced and most skilled gastroenterologist and endoscopist in the city of Jaipur. He is working at one of the oldest and most prestigious hospitals, the Santokba Durlabji Hospital in Jaipur, and he's the chief of the Santokba Institute of Gastroenterology. Anurag, please.
Well, thank you, sir. In fact, thank you so much, sir, for this very prestigious opportunity that you have given me to be able to talk on corrosive strictures of the esophagus, the endoscopic management. And this indeed is prestigious. Now, I hope you can hear me and you can see my screen. So,
Yes, sir, your screen is visible. We can hear you.
thank you, sir. So, Dr. Dash has already set up the base and makes my topic easier to discuss. Coming to the first slide, just a moment, there's something wrong. The slide is not changing. Just a second, sir. Yeah. So now, before we go on to discuss the endoscopic management of corrosive strictures, most of it actually entails dilatations, which means taking care of the strictures. And very rarely we do come across some complications which can be handled endoscopically in form of fistulas and bleeds. But I would largely be focusing on the management of corrosive strictures of the esophagus. And before we get down to start dilating these strictures, I always tend to gather a lot of background information before we actually do it. I personally evaluate them before doing the first endoscopy in form of a routine biochemistry and X-ray chest. The reason being that these are patients who come to us with malnutrition, who come with recurrent aspirations, and so I surely don't want to dilate them with ongoing consolidation, recurrent aspiration pneumonitis, and so on. The second study that I'm very happy doing is any form of oral contrast study, whether it be a barium or a gastrographin study, or maybe even a contrast CT. Then the whole purpose is I want to define the stricture well. How many are they? What is the length? Whether it is simple or complex. I'll come to simple and complex, but I would be very happy defining the complete stricture, the complete length of the esophagus before I start dilating. Of course, there is a caveat, a catch here. There is a tight proximal stricture. The dye doesn't go beyond that stricture so well, and we just might overestimate the severity of stricture because of less dye reaching the esophagus. At the same time, if the dye can give us some information about the stomach capacity, that also goes a long way to help us in deciding which dilator to use for the esophagus. CT scan largely is required only for complications if anticipated in form of either fistulas, if the patient has recurrent pneumonias or recurrent aspirations, or if the patient has had a lot of sentinel bleeds, then also I'm a little more comfortable checking the CT before I go ahead and dilate. I don't want to dilate and land up with a massive bleed. After having done this background check, it's easy to say whether the stricture of the esophagus. Now, this distribution is actually for any stricture, any benign stricture, but holds well for corrosives. So the stricture could well be simple or complex. The simple being very focal strictures, less than 2 centimeters straight, and it allows the endoscope to go through. The complex, of course, on the other hand, are long, tortuous, and they were very severely compromised lumen. It's good to know what the stricture is all about because that helps you plan your further course. So having done that, I tend to record, preferably in a diagrammatic representation on my sheet, the distance of the most proximal stricture from the incisors, whether it is simple or complex, and why, of course, and whether there are any diverticulae or ulcerations. But that also helps me decide when to dilate and how far to go. The stomach, whatever details that are available, should also be noted. We don't want to land up, dilating the stomach after you've done the esophagus. Good to tell the patient that we just might have to handle the stomach also at a later date after having dilated the esophagus. This background information helps me, one, predict and plan. So one, I can kind of predict the response. There are various studies, I've just picked up two. So there's one which says that if you have young adults, if you have caustic strictures, and the stricture numbers are more than 2, with of course they being complex, then they will probably require a lot of sessions of dilatation. There's another study, Dr. Brewer from GV Pant has done a lot of study on corrosives. He's published extensively on corrosives. And what he said in his study was, I was in fact part of collecting this data with him. I was a DM student then, is that the age, sex, grade of dysphagia and site, it really doesn't influence as much as it is the thickness of the esophageal wall. If you do a CT and the wall thickness is more than 9 millimeters, then this patient would require a significant more number of dilatations compared to the others. With this information, I can plan and also plan at the same time how best I will maintain the nutrition for the anticipated number of dilatation. This could go on for months and years. So I have to be very sure that I have to maintain the nutrition. Do I need a feeding jejunostomy? And when do I start dilating these patients? Before the first dilatation happens, a very, very important part of this program is to counsel the patient. Here is a disease which is not easy to manage. Here is a disease which will require multiple visits to the hospital. And therefore, we have to counsel these patients very adequately. Tell them the expected course. Give them the cost. They should be made aware of the results of the dilatation and especially the risk, which is perforation, because the perforation could be actually detrimental and lethal for the patient. Also, like I just mentioned, that if at all there is anticipated stricturing or reduced capacity of the stomach or antral stricture, then whether we will need endoscopic management or surgical management of this patient later on, that also has to be told to the patient. And I tend to tell my patients that why we are choosing on dilatations and not surgery, wherein I tell them a little in details about the extensive surgery that it requires and also the need of maybe dilatation even after the surgery because of an anastomotic stricture. So once the patient is very sure that he wants to go on an endoscopic dilatation, that's when the dilatation starts. The endoscopic treatment for corrosive stricture esophagus, of course, first is dilatation, and we have these various dilators. I'll very, very briefly discuss about them in the next slide. So if we are able to dilate, then I go ahead and keep dilating them as and when required. But if the first dilatation fails, then there are two possibilities. One is, of course, injecting intralesional steroids even before the first dilatation. And there's a round-the-way approach, which I've never used, but you go through the stomach, make an incision, take help of surgeons, go through the stomach, approach the esophagus in the retrograde fashion, and try and dilate. Of course, if these strictures are refractory or recurrent, and in a short while I'll tell you what is refractory and recurrent, then we have various other modalities in form of intralesional steroids or mitomycin C, even incisional therapy, and last of all, stents for these very refractory and recurrent strictures. Now, just to get this terminology right, refractory are the ones which I find dilating these patients at a 2-weekly interval. I've done about 5 sessions, so that's about 10 weeks, and I've not reached even 40 millimeters. So that's what it's called refractory. And recurrent is where we've been able to dilate them well. We've reached even up to 15, but the lumen diameter does not last even 4 weeks. And they keep coming back to you, and that's when it is called a recurrent stricture. So while I'm discussing the dilatation, it will be briefly on the instruments, the protocol, how much to dilate, and what are the results. Now, these are the three most common instruments used for dilatation. The top one is a polyvinyl Savary Gillard, as it is called, dilator. Second is a metal steel olive. And third is the balloon, the through the scope TTS balloon. Well, these three are the most extensively used. And coming to just a brief about these, we have these Savary Gillard dilators from 5 to 20 millimeters. The good part of these Savary Gillard dilators are they have a very good taper, so it's easy to dilate. The long nose actually helps in gradually dilating the stricture. But the bad part of this long nose is that if you have a strictured stomach, it will not accommodate the long nose, and that's where you will face the problems. And so if this is a strictured stomach, a low capacity stomach, you have these Eder Pesto EP olives, as they're called, steel, and therefore they're very good for tough strictures. The nose is small. So if you have a contracted stomach and a very tough stricture, that's where these olives come into play. All departments, I would suggest, who are into deeply dilating these corrosive strictures should actually have all three of them. Oh, sorry. I missed out on the balloon, the previous slide. Back. I can't get it back. I'm sorry, just a second. Yeah. So the balloons are good for very, very tight, narrow strictures. Even the smallest of the Savary or the olive doesn't go through. Then you can pass a balloon over the guide wire and then dilate the balloon, which leads to a radial force and without the shearing longitudinal force that the others have, which is a theoretical advantage. Also, one good thing about the balloon is it is done under direct visualization. But the worst part is that there is no tactile feel. With the other dilators, you know how much force you are using. Here, when you're dilating with a balloon, you just inflate it to the maximum size. Now, whether the stricture dilates or the stricture perforates is largely on the balloon size and not really so much on your tactile sense. I've just brought this slide for completeness. This is a bougie cap by Ovesco. I have not used it myself, but it looks interesting. There's this transparent cap in front of the endoscope. It goes over the guide wire, and you actually land up dilating these strictures under vision with the scope. I have not used it, and I'm not very sure if these tough strictures due to corrosives would be very, very comfortable dilating with this. Maybe for the others, yes. I couldn't find a specific report of this dilator being used for corrosives, though. Now, what is the protocol that we use while dilating? How much should we do in one go? So this rule of three, which has been described way back in about 2 to 3 decades back, very widely followed. We also do the same. It is basically based on blind bouginoids that was done that time. And they used to do it just beyond 3 millimeters of the first bougie which experienced resistance. However, over the years, this rule of three has failed to demonstrate much benefit. The only place where this rule of three should be very, very strictly followed is malignant strictures. They are the ones if you tend to dilate more, they leak very often. But at least in corrosives, we can go beyond 3 millimeters of the first dilatation that you do that day. And I quote one study where there are 297 complex strictures and they were dilated without adherence to the rule of three. And there was no high rate of complication. So I leave it at that because much depends on the experience of the endoscopist who can go beyond 3 millimeters of the first dilatation that he used on that particular day. Now, how frequently and how far do we go? Well, literature says every 2 weeks to even every week. We at our department follow a weekly protocol for the corrosives because they tend to become very narrow by the end of 2 weeks. So it's somewhere between 1 and 2 weeks. But yes, of course, no one is wrong if they're doing it at 1 week or at 2 weeks. There is an arbitrary assumption that we should go up to 15 millimeters maximum in corrosives. It is supported by the British Society of Gastroenterologists. What happens if you dilate more, at least in corrosives, there is not enough data. But for GERD strictures, it is well documented that if you go up to 18 millimeters, the recurrence is less. So we also in our department usually go up to 15 and rarely go up to more than 15, which is 16 or 17, if there are very frequent recurrences. The choice of instrument, what do you use? This is largely operator dependent. And there is one meta-analysis, 5 randomized controlled trials, and they have definitely without doubt shown that both bougie and balloon have equal efficacy and equal complications. And so what you have and what you have been using is what decides what you should use. The results of these dilatations, well, 10% remain refractory, 30 to 40% come back with recurrences, and 10% need very prolonged dilatation. There is this study of 123 adults, and Dr. Brewer published this study in Gut, very elegant study, which in fact, I always quote this study, that if we use this rule of 5 dilatations and then call it a refractory stricture, probably most corrosives will fall in the refractory range. He has shown on a more than 3-year follow-up that the recurrence rate significantly drops only after 1 year of weekly to 2-weekly dilatations. And it is after 36 months that the recurrence rate becomes comparable to peptic strictures. The studies, of course, have reported very varying number of surgeries that the patients actually land up with, from 2 to 3% to even up to 50% on long-term follow-up. The complications of dilatation, perforation, that's the most dreaded complication. I have purposely put up studies which have reported higher complications so that you don't take it lightly. And there are these 2 studies, again one from Dr. Brewer, where he showed that in 51 patients who were kept on long-term dilatation for even up to more than 1 year, there were 8 incidences of perforation, and that's quite a bit. There's a study from Korea. This supports, of course, a very high perforation rate with balloons, and that's up to 30%. But most studies tend to say that the percentage of perforation is less than 1%. The other complications while dilating are bleed and aspirations. Bleed and aspiration both usually do not need any endoscopic intervention. What happens when you fail to dilate in the first go? There is this very large series, the 340 patients, and I fail to understand how they got 340 patients wherein they could not even go in the first go. But so it says that if you're not able to dilate, come out, inject corticosteroid at the site of maximum resistance and repeat the dilatation 2 weeks later. The first dilatation would happen then in most, that is up to 75%. I'm not touching on the round-the-way approach because that's something very, very exhaustive that one would do. One would probably take up surgery rather than, incising the stomach and going retrograde into the esophagus and tend to dilate the esophagus without the results being very sure. So I'm not touching much on this round-the-way approach, which at least I have never used. Coming to refractory or the recurrent strictures, we have these options. One is intralesional steroid injection. Very heterogeneous results, multiple small studies. I quote one which was a randomized double-blind placebo-controlled trial. You give 4 quadrant injections, 0.5 ml each of the steroid. Maximum, of course, is 80 milligram. And what they showed was that there was significantly less need for repeat dilatation in the steroid group. That is 13% only compared to the 60% which happens in refractory or recurrent strictures if you don't inject steroids, which is triamcinolone local. The benefit is evident in all benign strictures, especially in the reflux and asthmatic, but also specifically in corrosive, one modality that we also tend to use quite often with appreciable results. There are reports of using mitomycin C instead of steroids, again for the same reasons, antifibrinolytic properties. And this pediatric study of 20 patients, they applied topically 0.4 milligram per ml, again reported a significant improvement in the number and frequency of dilatation required. Eventually, if you use them and the dilatation number and frequency goes down, that saves a lot of cost on part of the patient. And what is best is that both of these can be combined with other modalities, whether it be electrofusion that we do for refractory or recurrent, or even stents. Electrofusion is an endoscopic minor surgery. And what we here do is that at the site of, if the stricture is small, one, it has to be a small stricture, kind of almost like a diaphragmatic stricture. And up to 1 to 2 centimeters, we make linear incisions with a needle knife using the electrocautery on 4 quadrants. And having done that, we either leave it at that or put in a stent. It is a very useful adjunct to dilatation, though of course it is technically challenging. I have personally used it only once in a corrosive stricture without good result. However, I don't say that the technique is bad because I did not have a good result, primarily maybe because of less experience in using it in corrosive strictures. This is a technique very commonly used for in asthmatic strictures though. Last of all, if electrofusion also doesn't help, we have stents. And as I said, 10% remain refractory. We have 3 kinds of stents: self-expanding metallic stents. You also have self-expanding plastic stents, and lately biodegradable stents, like the ones that are available for the coronaries, are also available for the esophagus and also for the biliary tract. Now, these 3 stents, again, any one of these 3 can be used. Not much comparative analysis available, but what I could find is that the technical success of placing these stents is 98%. Placing these stents is easy actually. And this comparative analysis suggested that the metallic stent fared the best, giving 40% long-term relief. The biodegradable one had 30%, and these biodegradable ones usually dissolve by the end of 3 months. The plastic stent, of course, had the least appreciable results, which was only 10%. Problem with these stents is, though of course you're supposed to remove them from any time between 1 month, that is 4 weeks to 12 weeks, is that there is a lot of tissue overgrowth because of irritation of the stent margins in the esophagus. So the healthy tissue of the esophagus actually covers the margins of the stent. That's a protective phenomenon which the body follows. And that makes retrieving these stents difficult. So if you forget them for long or they left more than 3 months, then retrieving these stents might become an issue because of tissue overgrowth, which is the highest in plastic and the least in biodegradable. But I would end up with stents saying that till date, there is no ideal stent. The migration rate is very high, 30%, and that's a fair migration rate, with an overall clinical success being only 40%. It has to be removed before 12 weeks and should always be a last resort. But even if this last resort helps in 40% of the refractory strictures or the recurrent strictures, then why not? In the end, I present a treatment algorithm. This is actually for benign esophageal strictures, also includes corrosives, but our own experience and the experience at GB Pant is that most of corrosives will qualify go beyond what is said here. And therefore, we continue to dilate them despite them being called refractory or recurrent. So you dilate them with either bougie or balloon, go up to 15 to 18. If within 5 sessions at weekly or twice weekly intervals, you don't move ahead, then you combine these dilatations with intralesional steroid injections. If 3 sessions of steroids don't help, then you go ahead and use incisional therapy. And again, they have to be short strictures. And again, if 3 sessions of incisional therapy don't help, go ahead and put in a stent. And if that also doesn't help, then of course, you have to fall back on the surgeons like any other endoscopic therapeutic maneuver that we do. Thank you so much, sir.
Thank you, Dr. Anurag, for extensively elaborating on the endoscopic management. I think we will have discussion in the end when we have final question and answer round session.
Sure,
So,
sir.
yeah. So we will, I will request Dr. Chetan Kantharia, who is professor and head of surgical gastro at KEM Hospital, Mumbai, to speak on the indications of surgery and surgical management of corrosive stricture in chronic phase. So over to you, Dr. Chetan, please.
Thank you very much, Dr.
Sorry,
Dash.
just a minute. So before Dr. Chetan starts, Chetan is now heading the surgical gastroenterology department at one of the very prestigious institutions of the country, KEM Hospital, which has produced before him and then after him his trainees who are now working as surgical gastroenterologists in various parts of the country, including with me. And Chetan has, when I posted the message for this theme, he immediately responded and said that I would like to join because I know that he has a fairly large experience with management of corrosive strictures. Welcome, Chetan.
Thank you very much, sir. At the onset, I would like to comment that Dr. Govil gave a very excellent talk. It was indeed a treat to listen to him. So with this, I begin my talk that a successful conservative management of corrosive injury involves prompt recognition and early treatment, as we have seen yesterday. But in spite of this, and whatever Dr. Govil has said, that at times it is not possible to maintain an esophageal lumen, having taken all measures. And if I were to put number, then I would say around 10 to 30% of patients, they present with clinically apparent esophageal stricture requiring surgery. Now coming to indications for surgery. So they are patients who present with long strictures, multiple strictures, tortuous strictures, irregular strictures, and strictures which are refractory to dilatation. So these are the group of patients who would qualify for surgery after they have been attempted. All the maneuvers of endoscopy have been tried on them and they still have a stricture. Now arises a question is, when do we intervene? When do we intervene surgically? So animal studies have shown that peak collagen deposition occurs at the end of 2 weeks, and it continues to occur for a very long time. Though scar retraction is seen as early as end of 2nd week, it lasts for almost about 6 months. And the complete fibrosis, it keeps on evolving until 6 to 12 months after the injury. Hence, if one intervenes very early, when the scar has not been completely formed, there is a very high risk of anastomotic stenosis occurring because of the ongoing fibrosis happening. On the other hand, if we do a delayed surgery, the chance of successful surgical outcome is very high. And hence, everybody does intervene surgically at the end of 6 months after the injury. So this is the minimum period one should wait. That is a minimum of 6 months before you embark upon surgery. So now we have, having decided when to intervene. Now, what organ would you use as a conduit to replace the esophagus? So we have 3 options: the stomach, the jejunum, and the colon. So let us see the merits and demerits of each. The stomach, it stands the risk of having a long-term gastroesophageal reflux with acid refluxing, which leads to ulceration and ultimately stenosis. Besides this, it is also associated with progressive dysfunctional propulsion occurring. And it is not very uncommon to come across a situation when the stomach may not reach up to the neck, to the cervical region. So hence, generally, one does not use stomach as the conduit for esophageal replacement. As far as jejunum is concerned, the blood vessels of jejunum are very thin and friable, and it gets easily affected by the acid and fragile to the erosion of acid, and hence again jejunum is not used. Having said that, one uses jejunum as a jejunal supercharge, a segment of jejunum, when your esophageal colonic conduits falls short by few centimeters. So coming to colon compared to the jejunum and stomach has a robust blood supply, has an improved somatic growth. It is usually long enough to cover the distance till the cervical region, and it is associated with fewer complications of esophagitis and stricture because of the resistance to acid. And hence, generally everybody uses colon as a conduit for esophageal replacement for corrosive injury. Now comes the question that it's decided that we use a colon. Should we use a right colon or a left colon? Unfortunately, there are no randomized controlled trial comparing right versus left colon. And whatever studies are available in literature coming from the high volume centers show overlapping results, arguing in favor of both. But theoretically, the right colon has a very variable vascular anatomy as compared to the left. Though the right colon has ileocecal valve, which prevents reflux. And the biggest argument in favor of right colon is that if you have used right colon and for some reason the graft gets necrosed or it's not used, then you can always use left colon as a rescue colonic conduit. But having said that, generally all of us use left colon, though I'm very sure there are many who use right colon as well. Now comes the question is, what do you do with the residual esophagus? Should you resect it or should you keep it? And this is a controversial reason because we all know that scarred esophagus has an increased incidence of malignancy. But on the other hand, because of the adhesion and inflammation of the residual esophagus, which occurs following a long time caustic injury, there is a high risk of bleeding and sometimes leading to even mortality following esophagectomy. So generally, one does not resect the residual esophagus and you keep the patient on surveillance and follow up for development of malignancy, if at all it occurs after 30 to 40 years. But having said that, I know of some centers who do go ahead and resect the esophagus in our country as well. Now, so we have decided that we'll use colon, we'll use left colon, we will not remove the residual esophagus. How will you place or how will you transfer this left colonic conduit to the cervical region from the from the abdomen. So the posterior mediastinal route is out because you are keeping the native esophagus in place, and it is very difficult to ablate that esophagus. So the only option is the substernal route or the substernal tunnel, which you create. And one generally as a rule, or now as a protocol we follow, is that we do a partial sternotomy so that the thoracic inlet is wide enough and it does not compress the transposed colon and give rise to stricture or ischemia. So this is how one does a sternotomy, and you get a wide opening where you can easily pass in the colonic conduit and do your cervical anastomosis. So now once you have brought the colon above, how do you anastomose it? So you have you can either do a hand-sewn anastomosis end to end or end to side, whatever is the preference. We usually do an end-to-end cervical esophagocolonic anastomosis, or you can also do a stapled anastomosis as popularized by Oringer, where you make in an opening, introduce a linear stapler, and you staple, and then you close the opening which you have made to introduce the stapler. So this is as far as the proximal anastomosis is concerned. Distally, you will anastomose it to the stomach if the stomach is healthy, or if the stomach is also involved, then and you have done a partial or a complete gastrectomy, then you anastomose it to the loop of jejunum. So this is as far as the surgical technique is concerned. Now, to complete, though the mandate is only corrosive stricture of the esophagus, I will touch upon management, surgical management of pharyngoesophageal stricture also, because it commonly you come across this situation where the pharynx is also involved. So as Professor Anand Krishnan has divided patients of pharyngoesophageal strictures into 6 groups, I will give you the groups and management of each. So group 1 is where patients have a residual lumen and you can pass in a guide wire. So in this case, you can give these patients a trial of dilatation, and you give a trial long enough. And if they do not respond to surgery, then they should be subjected to cervical esophagocoloplasty. In group 2, there is no demonstrable lumen and you cannot pass the guide wire. And this stricture is in close proximity to the laryngeal inlet, leading to respiratory embarrassment. So these patients, what one does is you do a cervical esophagostomy and you do a retrograde dilatation by passing in a bougie and you establish a passage so that you get a well-matured tract. And once you a well-established lumen, a matured lumen is made, you go ahead and do esophagocoloplasty distal to the dilated stricture, and the esophagostomy usually closes down on its own. Then the third group is where you have a short segment of pharyngoesophageal stricture because of the granulation tissue or synecdoche. So in this case, you have to take help of your ENT colleagues, and you do excision of granulation and adhesolysis under vision with a direct laryngoscope. And this should be done, if necessary, more than once. Many a times we have also done laser ablation of this synecdoche. And then once you get to see the lumen, all the synecdoche has been removed, then you dilate the tract to obtain a stable lumen. Grade 4 is a dense, non-dilatable stricture of the pharyngoesophageal junction with a normal distal esophagus for at least 5 centimeter length distal to the pharyngoesophageal stricture. So in this case, you do a cervical esophagostomy, lay open the pharyngoesophageal stricture, thereby exposing healthy pharynx above and a healthy esophagus below. And the large defect which is created is closed with using a myocutaneous flap. Usually you can use either a deltoid flap or a pectoralis major myocutaneous flap. And if there is stricture below the normal esophagus, then you can dilate it at later stage. And if it is not amenable to dilatation after you have given enough trial, you can then subject this patient to esophagocolic bypass after 6 to 8 weeks. And coming to the last two groups, that is group 5, whereas there is destruction of the larynx, then you do a permanent tracheostomy, follow it up with pharyngocoloplasty, and then you do a pharyngocolic, where you do a pharyngocolic anastomosis above the stricture, and usually you do a side-to-side anastomosis. Group 6 is where no lumen is detected in the cervical esophageal segment. Beyond this stricture, including your contrast cannot delineate it, contrast examination cannot delineate it. In this case, you do a trial dissection, neck exploration, see if you can identify the esophagus. It is usually cicatrized and very difficult. But if you are lucky enough, if you get it, you can do a esophagostomy. You do a retrograde dilatation above and below both. And once a mature tract is available or formed, you can do a esophagocoloplasty. But this is very easily said than done. Usually, you do not get the esophagus and no lumen is demonstrable. So in this case, this patient remains on a permanent either feeding gastrostomy or a feeding jejunostomy. And the last part is, what do you do with the corrosive injury of the stomach, either isolated or in conjunction with esophagus? So in this case, depending upon the extent of the involvement, again, there is a classification given by Dr. Anand Krishnan. So if it is proximal is involved, then you can do a partial gastrectomy. And if there is the entire stomach is involved, then you do a complete gastrectomy with either esophagostomy or esophagus is also involved, then you take a loop of colon above and anastomose it to the jejunum below. So thank you very much. As I said, I would keep it very simple and to the point. Thank you.
Yeah, thank you, Dr. Chetan, for this nice talk on the surgical management. I'm sure with the audience of dominant surgeons, there will be many questions for you in the discussion session. So we move on to the next speaker. He will, Dr. NishaathusseinNaushad. He is working as a Dar EsSalaam Hospital, Tanzania. So I think I will request Dr. Kapoor to introduce the speaker. Yeah.
So Nishat is a young surgical colleague from Tanzania. He joined us in the Jaipur Surgical Festival recently. He has been attending the Jaipur Surgical tutorial classes very regularly. He is very keen to come to India for about a year for further training. So I would like to request all my colleagues who are here to please entertain his application as and when it comes, including Dr. Chetan, Dr. Dash, because I would want him to spend about 3 months each at 3 or 4 centers so that he can get exposed to the special areas of interest which we can offer to him. In fact, one of his other colleagues from Tanzania, Dr. Vihar Kotecha, is already in India. He is with Dr. Beju Senadhipan at the moment. He's going to join Puneet Dhar for some time. And if he wants, then I will request either Dr. Chetan or Dr. Dash to enter.
Sure, definitely.
And so Nishat again volunteered that he would like to speak, and I was very happy. And I think this is his first presentation in the masterclass. And I would request all the senior colleagues to please convey to him personally how to improve his presentation further. So Nishat, thank you very much for volunteering to make a presentation. Please start.
Okay. Thank you very much. I'm very grateful to Professor Kapoor for giving me such an opportunity to present in such a prestigious forum. And I hope I can do justice to the topic. It's my first time presenting on this forum, so please correct me and guide me further. Thank you very much. So is my screen visible, sir?
Yes, please do. And
Yes,
you don't
okay.
have to
So
say that. That is also our job as your teachers, that wherever we think you can make it even better, we will definitely point out to you. All the senior colleagues will do that. Don't worry.
thank you. So today the topic I've been given is corrosive injury and the risk of cancer. So this is going to be my outline. I'm going to introduce the topic briefly, and then I'm going to talk about certain nuances in the diagnosis, the management, and the prognosis, and finally I'll summarize it. So esophageal cancer is one of the late complications of gastric stenosis. Any ingestion of corrosive acidic or alkaline injury, especially the severe, moderate to severe cases which cause stenosis, increase the risk of esophageal cancer by about 1,000-fold. However, the literature is not very strong to convey the exact risk of esophageal cancer. The incidence is reported to be between 1 to 4%, and the most common histological type is squamous cell carcinoma, and mostly in the middle part of the esophagus. The occurrence from the time of injury takes about 3 to 4 decades. However, in literature, it can be much more earlier or much more later. The exact mechanism of cancer development is unclear. However, because of the stenosis and the narrowing, there is stasis, which leads to chronic inflammation and chronic irritation of the esophageal mucosa, which increases the risk of development of esophageal cancer. Also, repeated endoscopic interventions and dilatations lead to ulcerations and can also lead to the cascade of development of carcinogenesis and development of esophageal cancer. In literature, the first incidence of esophageal cancer related to gastric injury was reported in 1904 by Teleke in a 22 years old male who had a history of acid ingestion at the age of 2 years, and the esophageal CA was found at autopsy with the mid part of the esophagus which had perforated into the left bronchus. Thereafter, many studies have been reported to show the association. However, because of the long duration from the injury to the occurrence of esophageal CA, it takes a long period, decades. Follow-up programs are not very well formed, and because there might be also loss of follow-up, and in poor and developing countries, some of the cases might even go unreported. So the true incidence is still unknown, and therefore the need of national database. In the literature, the shortest duration of ingestion to occurrence is reported by Rohit Jain et al. In a 14-year-old Indian boy who develops squamous cell carcinoma with cervical lymph node metastasis just 1 year after the ingestion of corrosive agent. So the gastric stenosis of esophagus depends on the product, the amount, the concentration of the ingested material, also the intent. I'll not go deep into that. This has already been discussed. But Kochar and colleagues suggested that esophageal acid ingestion might be associated with a lower risk of development of carcinoma than alkali ingestion. And this is because alkali tend to stick to the wall of the esophageal more because they react with the proteins and lipids on the wall of the esophagus, causing saponification and effective necrosis involving the deeper layers of the esophageal wall and more prone to severe strictures and therefore increase the risk of esophageal CA. However, when the concentration and the amount is large, this difference becomes negligible. Rao et al. In his study showed that squamous cell carcinoma was diagnosed in 80% of cases as the most common histological etiology, others being adenocarcinoma and other forms. And the most frequent age of occurrence was between 40 and 70 years, mean being 59 years. Coming to the diagnosis, the diagnosis of corrosive esophageal CA is more difficult in carcinoma caused by corrosive injury rather than de novo esophageal CA, because these patients have already been suffering with dysphagia for a long period of time, so their symptoms may be attributed to the symptoms that they already have been complaining for a long period of time. And so clinically, it is very important for any new dysphagia or any worsening of dysphagia and weight loss should be alarming sign of development of malignant transformation. Endoscopic evaluation and surveillance plays the main role in diagnostic esophageal. However, some literature shows its limited role. And the occurrence of cancer is in the areas of narrowing and stenosis. Therefore, it is in these places that the endoscopists must focus their attention in order to look for pre-cancerous lesions and biopsy for the diagnosis. Newer techniques like endoscopy and neurobed imaging increase the yield of detection of carcinoma. Penacci et al. Is a study of patients with severe cystic stenosis. All the patients underwent lugol iodine endoscopy and neurobed imaging, and he concluded that the general acuity of the exam was 73%. So all the suspicion lesions, biopsy was taken, and he said that all the lesions were at the narrowing or at the stenotic site. So this is a case report by Jun Zhang et al., who reported 61 years old male who had a sulfuric acid injection at the age of 3 years and presented 58 years later with severe dysphagia of grade 5. Initially, he had reported 1 year prior to this incident with mild dysphagia, which was ignored. And now he had presented grade 5 and significant weight loss. This is the barium swallow of the patient, which shows a long stricture at the mid part of the esophagus. And for the same patient, the endoscopy, it shows the luminal narrowing with no any suspected lesion around the narrowing. However, biopsies were taken which were negative for carcinoma. But because of worsening dysphagia, CT was done and the patient underwent esophagectomy. In the pathological specimen, he was found to have a T2 squamous cell carcinoma. So the reason for bringing up this case is to show that in esophageal CA caused by corrosive injury, one modality of investigation might not be enough. It needs a combination of modalities, and any clinical suspicion should be high for any worsening of dysphagia and weight loss. And because early detection leads to improved survival, it is important. So there was a paper by Seung Buno et al. In 2017 in Korea, who retrospectively studied all the patients who had severe corrosive injury from 1989 to 2015. And of these patients, those who developed esophageal carcinoma in the follow-up, he reviewed all the esophagograms and CT scans. However, this study is not very strong because it is a retrospective type of study and small sample size. But he concluded that esophagograms and CT scans play the predominant role in the diagnosis of esophageal CA secondary to corrosive injury. Where he showed that on esophagograms, 27% of the cancers were found at the stricture site. The most common morphological type was polypoid stricture. Mucosal irregularities were found in 92% of patients. The mean length of involvement was around 5 centimeters, and rigidity, that is loss of esophageal mobility, was in about 69% of patients. CT findings showed eccentric wall thickening in 71% of patients, homogeneous enhancement in 69%, periesophageal infiltration in 79%, and the lymph nodes either mediastinal or hilar of more than 1 centimeter in 14% of patients. And these are some of the images from his study. This is a 49-year-old woman who had sulfuric injection 23 years ago, who shows a sort of fungating mass at the mid portion of the esophagus with extension to the proximal part and circular dilatation just proximal to the stenosis. This is another 62-year-old lady with histophy injection, and the esophagogram showed that depression type of lesion just proximal to the stricture site with the convergence of the esophageal mucosa. And this is the resected specimen after Ivory Levis esophagectomy, which showed squamous cell carcinoma. This is a picture of 8 years old lady who had, this is the same lady who had corrosive injury 40 years ago. This barium swallow was taken sometime before, showed a uniform small segment uniform and small segment and tapering narrowing at the proximal part of the esophagus, which was shown to be benign. After a few time, in the same lady, there was a long, long stricture at the mid to distal part of the esophagus with sharp narrowing and irregular narrowing. It was diagnosed to be carcinoma. This is the image of the CT scan showing a esophageal wall thickening with periesophageal infiltration and homogeneous enhancement. Colonoscopy should be performed in all cases who are planned for surgery. Coming to the management of patients with esophageal CA secondary to gastric injury, the main treatment modality is resection, esophagectomy. However, the literature records a reduced percentage of esophagectomies performed. Most of these patients undergo radiotherapy or combined therapy, radiochemotherapy, and palliative procedures as feeding tubes. One of the controversies in the surgical management is that some authors, on one hand, recommend to prophylactically resect esophagus because in some of the studies, the prevalence of esophageal CA in patients with severe gastric injury is shown to be high. For example, in the study by Kim et al., we showed about 13%. So this is a significant number of patients. And also, early surgery prophylactic resection of the esophagus obviates the need for lifelong dilatations and risk of perforation. On the other hand, most of the authors, they avoid routine esophagectomies because they say that there is high risk of morbidity and mortality because of the significant fibrosis. And there is relatively lower risk of malignant transformation as shown in other studies. And those who support, and those patients who undergo bypass, there is even further reduction of the risk of malignant transformation because there is no stasis and there's no irritation of the mucosa, and carcinogenesis risk is reduced. So I think there are many experienced surgeons in this platform that will help us to. So this is a table which shows multiple publications from different parts of the country, from earlier periods to recent studies. We show the number of patients with gastric injury, those who develop carcinoma, the time period from the injury to the diagnosis, the number of patients undergo esophagectomy, and the 5-year survival. So only 2 studies I want to point here. That Kim et al. Study in Korea in 2001 showed that 13% prevalence of esophageal CA in patients with gastric injury, and the time from injury to diagnosis was the shortest, 12 years. While in a study of Govil et al. In Italy in 2010 showed the lowest prevalence of esophageal CA in severe gastric stenosis of 0.8%, and the longest period from injury to occurrence. And number of esophagectomies are few, but in the later studies, it shows that the 5-year survival is about 50%. So prognosis, survival rate of patients with gastric injury is better than de novo esophageal CA. So 5-year survival is about 45 to 50%, and 10-year survival is about 10%. The prognosis of gastric injury-induced carcinoma is better because of some of the theories mentioned in literature. One of it is that because there is a fibrosis, the growth of the tumor, significant portion of the growth of the tumor is intraluminal, and therefore early worsening of dysphagia and can be picked up easily. The second thing is that these patients have lifelong dysphagia, and they undergo repeated endoscopies and dilatations, so they can be picked up earlier. And the third thing is that the peritumoral intratumoral fibrosis limits the spread of the disease to adjacent organs and to lymph nodes, and therefore it has been shown to have a better prognosis than other forms of esophageal CA. Lastly, I want to mention one of the study over here of Govil et al. In 2010. He showed that of his resection of those patients diagnosed with esophageal CA secondary to chronic gastric stenosis, esophagectomy was done in 68% of patients. The mortality rates was 40 and 40%. Morbidity and mortality rates was 40 and 4% respectively. The 5-year survival is 52%. And when comparing non-scar carcinoma to scar carcinoma, he showed that those with scar carcinoma had a significant peritumoral fibrosis, and this led to higher prevalence of tumors detected in the early stages, T1 and T2, and less lymph node metastasis, and this data were clinically significant. And also the 5-year survival for patients with scar carcinoma was better in those who are resected and those who are not resected. So to summarize, there's increased risk of malignant neoplasm and prostate injury recorded 3 to 4 decades after the injury. There is no gender preference. Smoking, alcoholism increases the risk of cancer. Also, reflux disease might increase the risk of cancer. Squamous cell carcinoma is the most prevalent histology and occurs mostly in the areas of stricture, mostly in the mid part of the esophagus. Diagnosis of neoplasia is difficult, and periodic endoscopic follow-up with biopsies is necessary for all patients with history of prostate ingestion, at least after a certain period of time, every 2 to 3 years, even if they do not present with dysplasia. Biopsy should be obtained close to the areas of stricture where neoplasm arise. Early diagnosis and treatment further improves 5 and 10-year survival, and prognosis is better than other forms of esophageal CA. And there is high incidence of prostate injection in some countries, and this highlights the need for implementing prevention programs, adult education, and national database to further define properly the risk of of the incidence of esophageal cancer in such a group of patients. And finally, I want to thank the opportunity to present in this wonderful platform.
Yeah, thank you, Dr. Naushad, for your elaborative literature review on the topic of malignancy in the setting of corrosive injury. So I think we can start. Is Dr. Dash here?
Yes.
Yes, he is there.
Yeah, please.
Yeah,
Now get the ball rolling.
Yeah, I must congratulate Dr. Nishad in his first presentation. It was very elaborately dealt with, very nicely dealt with depth. I must admit that I have attended many forum where people actually do not take this aspect of the corrosive stricture, that is malignancy, very seriously. Whenever we start discussing, they say that it's a very old literature. We have never seen cases like this. But after your presentation, I think it tempts me to take the thing seriously and maybe more discuss about it. This has been a short question, and I think the students will be very benefited by your presentation. It's a complete coverage of the thing. Oh, what actually puzzles me is, number one, now how do we say that after 40 years the malignancy is not de novo and it's because of because of the scar? If we say it is a scar, then from where the squamous cell tissue comes? Scar is a fibrous tissue only. We can at best say, if we compare or with the burn of the skin, then there occurs scar carcinoma or Marjolin's ulcer. Are these which are of good prognosis? So it could be because of it could be similar to that from where it comes. That's what really puzzles me. And see, once a patient gets a corrosive injury, particularly if they are very high-grade injuries, I'm not sure, particularly the pharyngoesophageal strictures. I haven't seen any report of malignancy occurring in pharyngoesophageal strictures. And the pharyngoesophageal stricture population, it's very difficult to survive for that long, 40 years or so after the injury and stricture, to have a malignancy. Then I think there are a lot of areas which are not answered, and maybe they have been masked by the fact that we ourselves haven't seen much of the cases. I personally haven't come across a single case during my 25-year career here. But it was very nice, very nice. And I would suggest here that Dr. Professor Kapoor has a presentation where he presented. I do not remember exactly how to present. I think you should try to retrieve that presentation. It was in the internet, and it's very elaborately he has stated the nuances of presenting of presentation.
Okay, so maybe we can have the open house session now. We have plenty of time.
Certainly go through the video.
So, shall I? Because yesterday I was traveling, so I was not very well connected. I had some questions trying to read what goes on in the student's mind. So maybe I'll put those questions. Harindra is not there, but I think two of you can take, and some answers Dr. Anurag also can. My first question is, there is some echo. My first question is, do we go by the clinical condition of the patient, which means whether the patient has hemodynamic instability, features of sepsis, counts, CRP, ABG, which would indicate the severity of the injury and also whether there is a perforation, or is it that in every case we have to do an endoscopy and or a CT scan? So to elaborate, suppose the patient took the ingested the corrosive, say 2 days or 3 days ago. Patient today comes to us, is otherwise all right. She says that I have been drinking also and I have no problem. So most likely this patient has a minor or a low grade injury. So do we still need to do endoscopy and CT? On the other hand, there is a patient who is obviously sick, looks in sepsis, has severe pain either in the medial chest or in the abdomen, has the clinical features of a perforation, or a plain X-ray shows some extra luminal air. So do we still need to do endoscopy and CT? What is the opinion?
Yeah. Can I answer this question?
Yes, please.
Yeah. See, in fact, a patient who is sick, there is no doubt, who shows clear-cut evidence of perforation or mediastinitis. I don't think he needs endoscopy. He needs surgical exploration. So there is no role of doing endoscopy in such a patient. In the first scenario where you have been telling that the patient 2-3 days coming and he or she is eating and drinking everything, I think it is still imperative to do a endoscopic assessment and grade the injuries, because it has been seen that up to 12%, 12 to 15% of the patients who are asymptomatic at presentation can go on to develop stricture. So it is important to grade the injuries in all the patients.
Okay. The second question, maybe Harindra covered it, but because I was not well connected, I could not hear his entire presentation. In a patient with acute corrosive injury who comes, say, within first 24 hours or so, the injury to the respiratory tract is more important than the digestive tract, because that can be life-threatening. So what evaluation a student or a practicing surgeon should do to evaluate that? What are the alarm signs which indicate that we should immediately get the help of an anesthetist who can either intubate, or a surgeon who can do a tracheostomy if it is required? So what are the alarm signs of a respiratory injury?
Yeah, I think it is stridor, hoarseness, and difficulty in breathing. Because whatever the situation is, whenever there is corrosive ingestion, some of the fumes, they tend to go to the trachea and airway only, so they can cause some amount of edema. So it is the edema which is usually obstructing in the initial part. And subsequently, if some corrosive is ingested, that can lead to some tracheal necrosis or bronchial necrosis. That is a later event. But immediate, it will be edema. And if a patient is breathing well, he or she is not tachypneic, and saturation is maintained, we need to observe them closely. And if a patient develop any of these signs, it's better to do intubations, and all the intubations has to be done under guidance. No blind intubation should be done, because blind intubation, missing the larynx and going into the pharynx, can potentially cause perforations and complicate the issue. So if there is a difficulty in finding the lumen, even under endoscopic guidance, it is better to go in and do a early tracheostomy rather than making another attempt to do the intubation.
In fact, this underlines the importance of local examination of the inlet.
Yeah.
So yes, I think the apart from that, the situation could be either very obvious that the patient is having aspistic symptoms, striders, etc., etc., and just put a pulse ox. Either it looks blue or put a pulse ox. You can see what is the saturation. But more than that is the examination. Means sometimes these are actually not so aspistic. The saturation could be just plus minus, but you examine the mouth and the larynx, and we find there is severe burn. Sooner or later, these guys are having patients are going to have a problem. So watching masterly inactivity as well as watching them very carefully and continuously is very important. And Ajay says we should have a very low threshold of doing a tracheostomy in these patients.
I remember that before the role of CT came in a few years ago, it was only endoscopy which was the investigation. And I always used to tell the students as well as practicing doctors that unless you have a highly experienced endoscopist like Dr. Anurag, one should probably not attempt an endoscopy in these patients, because if it is done by an inexperienced endoscopist who hasn't handled a corrosive injured esophagus earlier, who is not aware of the precautions which need to be taken and the softness with which endoscopy is to be done, it sometimes can cause more damage, because endoscopy is mainly to assess the severity, which decides the degree of management. And as was mentioned yesterday, or maybe by Das today, that all this also has a background of the insurance cover, which is the US practice of medicine. And therefore, today, when there is a role for a CT scan also, as was highlighted yesterday, that first a plain X-ray chest and abdomen, then a non-contrast CT, then a CT with IV contrast, and then an oral contrast CT. Because CT is available at most centers, but help of an expert endoscopist and experienced endoscopist may not be available at every place. So what is your opinion that if you are not sure about the skill of your endoscopy colleague, whether CT should be the first investigation after plain X-rays and you should reserve endoscopy for later evaluation as and when stricture forms? Maybe Dr. Anurag can comment on that first, and then one of the surgeons can.
So I don't deny two things here. One is that you have to have a very experienced endoscopist doing the endoscopy. The need for endoscopy is not debated any longer. It was at one point of time, but today the need is not debated because the type 1 and the type 3B kinds, the two extremes, if you find, the management changes. One is a early discharge and second is maybe a preemptive, surgery, or you being ready for the immediate emergencies. So one is, yes, a very experienced endoscopist has to do it very gently, low insufflation, and they should know where to stop. That's most important. So even if I start doing an endoscopy, if I don't know where to stop and I have to do the full endoscopy, then I could go wrong so many times. So that's one part of it. And the second part is when to do a CT if you're not doing an endoscopy. I would say largely it's the clinical condition of the patient that will then decide whether we do a CT or we don't do a CT, because it is only the clinical condition which will tell us what to do. Finding a chance perforation is very unlikely. And so the CT is very, very unlikely to change the course of illness, will really not help much. I would personally not do it if the endoscopy is not being done. I don't know what the other panelists would have to say to that.
Besides the information obtained from endoscopy, you will not get it on CECT scan. CECT scan at the most will tell you the thickness and whether there is circumferential involvement in the length. But the exact morphological picture, you will not get it on CECT scan.
True.
No. In fact, as per the CT grading, if it is grade 3 injury, I mean, I am not contesting on the role of endoscopy is a must, but CT can be adjunctive, particularly in high grade injury when we see grade 3 injury or grade 4 injury, where we can see non-enhancement of the gastric wall or non-enhancement of the esophageal wall after giving IV contrast. Then it becomes an indication of doing a early intervention and early surgery in these patients.
So Vikas,
So
as you
CT
said, it's an adjunct.
Yeah, it's an adjunct.
Yeah.
I don't contest on that. Yeah.
So for the benefit of Das, you want to say something, please? Yes, Das, please go ahead. आप muted हो, unmute कर लो.
Yes, I have. My observation is, rather our departmental observation is, we usually get two groups of patients. One who come really hemodynamically unstable, and in those patients they are in a state of shock, and in those patients you have no time to they are not fit for CT scan or any other intervention, and they are also not fit for surgery. So we have never been able to take them for surgery if they are really unstable. Now, in those cases, even a simple chest X-ray and abdominal X-ray, if it is suggestive of frank necrosis or gangrene, so we take those patients straight away for surgery whenever they are fit for surgery. If they become stable over a period of 24 to 48 hours, and then question comes whether you should do a endoscopy in these patients or not. Now, in many forum, I have witnessed the people say that if you really do, particularly I've heard Dr. Ananthakrishnan saying that he is not, he doesn't do endoscopy within 48 hours or 72 hours. He used to do it after 7 days, and he believes in doing a re-endoscopy after a second week or so. Now, my question is whether we can actually what are those group of patients where we can really avoid doing a endoscopy. Like for example, a patient who has taken 20 ml of acid and immediately he throws out and comes to you with burning chest pain or so. So particularly in our just in front of AIMS, there is Safdarjung Hospital. A lot of patients come there, go there for with this type of injuries, and about maybe 70% of them, even more than that, they would be just managing 1 or 2 days with IV fluids, then start orally just on the basis of history and the examination, and then on third day or so they would start orally water and so, and then they would definitely discharge the patient. So is there a case like that, Dr. Anurag?
I will go back to what my initial statement was. Again, I'll repeat that. Suppose there is a patient who swallowed some corrosive 2-3 days ago, and the patient today, after 2-3 days of the corrosive intake, is hemodynamically and septically stable. There are no features of instability. And she says that she has been taking liquids. What usually practitioners will advise, take cold fluids, take cold milk. And she says she's been doing that. And she's otherwise all right. Do we still do an endoscopy or we wait and see what happens? So this is one group. Can we avoid an endoscopy? Dr. Anurag.
Yes, sir. Clinically, I would agree totally. I mean, not that all 100% should always undergo an endoscopy. The ones who you get in history of maybe a very small swallow or having, spit it out as soon as they realize that this was an acid, and who are absolutely and totally clinically stable, do not need an endoscopy. And I would personally not always do an endoscopy. The timing, at least in our department, we tend to do it within, if we have to, within 48 hours. I'm extending the answer to this question is because I want to bring in a point where Sir mentioned that there are some who want to do it at 5 days and even up to 10 days. Now, there are two aspects of wanting to do an endoscopy after 48 to 72 hours. One is, of course, to grade the severity better. And second is, uh, is it safe to do it at that point of time? And third is there a therapeutic benefit there and then while you're doing an endoscopy? So two or three reasons to do the endoscopy at a later date are, of course, grading it better. The risk of doing endoscopy after 72 hours is, I think, again, as you mentioned, if you have an experienced endoscopist, really there is not so much of a risk. People have gone to the extent of doing endoscopies from between 10 days to 15 days and much before the end of 3 weeks and actually dissecting the synecdoche which form between the walls so as to try and decrease the incidence of strictures at a later date. So here you have such aggressive endoscopists who trying to dissect of course you have to do it absolutely and totally carefully, but you have aggressive endoscopists who kind of, are partially dilating it by cutting the synecdoche. So safety is not an issue. You can grade it better by doing it later also, no doubt about that. And then there are times when they come with those sentinel bleeds, or they come with definite or at least partially suggesting complications in form of fistulas, large fistulas, that you just might want to do an endoscopy at a later date. So not for all, yes, there could be some incidences where you would not do it, clinically unstable or very stable. And the timing, we don't have to stick to it that real bad. I think, yes, if you do it around 3, 4, 5 days, of course, we don't do it. We do it in the first 48 hours. But I've learned at least from so many people that it's safe doing it at a later date also.
And the second part of the question, again, for the students is that now, because these are two key investigations in a patient with acute corrosive injury, is the CT to be done in all patients? If not, then in which patients it is not required and in which patients it must be done?
So wherever it is clinically indicated, not for all for sure. So clinically indicated means unstable patients, you're suspecting a complication. And like sir just mentioned, if the patient is very unstable, at least the endoscopy has shown grade 4 changes, and you want to find out what the stomach status is like, which need not necessarily be seen on an endoscopy because you wouldn't inflate the stomach as much as you would want to. So those would form some indications for doing as early CT. That's what I would also personally do.
And would you agree with what was mentioned yesterday that first you do a plain CT to look for free air, then you do an IV contrast CT, and then if you suspect a perforation, you do an oral contrast CT, so in 3 parts?
So that can be done there and then on the table. So there is really no harm in trying to follow that protocol. These are sick patients, they could well have renal compromise. So any added one procedure and second expenditure is worth saving. So, but when we do it, we give the oral contrast, and we also give the IV contrast in the same go if the patient has no renal compromise. We usually don't follow the protocol of doing just a non-contrast first, and because if there is perforation and if there is contrast spill, it doesn't really deteriorate the patient. And so we personally don't follow it in 3 stages. But if someone is doing it and is being extra cautious, I can't say why you're doing it. So
Vikas,
But I think we always prefer to do a non-contrast CT first and rule out any pneumomediastinum or pneumoperitoneum, because howsoever sometimes a small perforation can lead to a small pocket of air which is not picked up on routine radiograph. And then once it is ruled out, then we can give oral and IV contrast both.
absolutely well taken, sir.
Yeah.
Absolutely well taken.
I think, in my opinion, when a patient is admitted, means someday, somewhere down the line, he would need a CT scan, but it's a matter of timing when you should do it. If he's stable patient and injury is of higher grade, or clinically we are plus minus in suspecting whether he has a chest, he has a mediastinitis, he has a peritonitis, we are not very sure, mild tenderness here and there, then it's worth that rather than doing 3 CTs, we wait and watch the clinical signs. If they're not deteriorating, maybe after 72 hours or so, we can have a CT scan. That's a matter of debate. That's what I'm saying. So we use only one CT scan, and most of the time, because of the oral injuries, oropharyngeal injuries, or the pharyngolarynx injuries, they are unable to drink the contrast, swallow the contrast. So there, that's why we do non-contrast in all of the cases as the first step.
There are three questions on the YouTube which have come to me.
Sure.
I will read them out. Dr. Ankit Sharma wants to ask Dr. Chetan, do you not use gastric conduit at all? Or if you use it selectively, then when do you use stomach in preference to colon?
We never use gastric conduit. We always use colonic conduit.
Is there a situation where colon may not be suitable?
No, sir. As a rule, we always do a colonoscopy for all our patients prior to doing that, though it is not a must, but it's a protocol. So if there is a diverticulitis or if there is some disease, then we would defer using it. But otherwise, as a rule, we always use colonic conduit.
And sorry, I missed some part of your presentation in between. Do you do a colonic angiography also?
No, sir. We don't do a colonic angiography unless the patient is means there is a pre-disease, that is he's suffering from coronary disease or is atherosclerotic. Only in these group of patients we would do it.
But most of these patients are usually young patients.
Young patients, yes.
Then Khalid Durrani wants to ask, has a comment, maybe you can respond. Another indication for surgery would be perforation on dilatation when endoscopic stent is not available.
Yes, that is one of the indication, but it's not an elective indication, it's an emergency indication. In that case, you would do it. Again, the same thing, depending upon where the site of perforation is, you plan your surgery accordingly.
But
In fact,
for an endoscopy induced perforation, I mean, from exam point of view, the treatment of choice would be stent.
Yes. That is one of the indications where you should definitely use a stent. Self-expanding metallic stent will be very useful.
in that case, we need to use a covered metallic stent.
Yes, yes.
And secondly, I mean, regarding this query about perforation in the setting of corrosive, sometimes there can be anecdotes. I mean, this can be exception to the situation. You need to observe the patient closely because of the lot of fibrosis laid around the esophagus. Sometimes these perforation can be very well contained in the fibrosis itself. If the patient is not clinically deteriorating, there is a case for managing these perforations conservatively as well.
So, Dr. Anurag, what would you do? Suppose you are doing endoscopy and you have recognized during endoscopy or say afterwards that there is a perforation. What is your approach?
So if we detect a perforation there and then on the table, we would always stent the patient. I don't say that all would not heal by themselves or with conservative treatment, but you can't actually predict the ones who will get into localized collections and sepsis. And that chance should actually not be taken, because if you delay the stenting, then things become very troublesome. One, it makes it more difficult for the surgeon to handle the patient. And of course, the general condition can rapidly deteriorate. So I would say if you detected an endoscopy on the table, always stent the patient and not wait for a conservative trial. Yes, if you get to know about the perforation a day or two later, that is when a CT scan will tell you what would be the best approach.
I think when Vikas said
And
observation,
also,
probably this was the subgroup that already 24 or 48 hours have passed, patient is otherwise stable. Maybe you can show whether it has already closed or contained.
Yeah.
Last wanted to.
and I, of course, that is the end of the road. I believe that is the end of the road for further dilatation. Or sir, Dr. Anurag, is it possible that, so suppose there is a contained perforation, it has healed, is there any scope of further dilatation, or they are 100% surgical patients?
Sir, a previous perforation is almost, I wouldn't say it's an absolute contraindication, but is a contraindication for future dilatations.
By and large.
Take a colliery from, say, achalasia. You do get patients who have had a perforation, a very, very minor leak which healed on conservative treatment, and who was earlier. Now, of course, we would go for poem or something of the same sort, but they were dilated even after a history of perforation in the past. But I would treat it as almost an absolute contraindication.
I think for the students, perforation should be a contraindication for dilatation.
Yes, sir.
A corollary to that, what are other contraindications for dilatation in a corrosive stricture?
So, if we have a deeply ulcerated esophagus at the end of 3 to 4 weeks, I would not dilate then and wait for a while, wait for at least another 2 weeks, of course, not beyond 8 weeks, because then dilating the esophagus becomes more and more difficult. The strictures become very tough. But that's really not a contraindication, you're just delaying it. Second is suspected, you have those, like I mentioned yesterday. So we had this patient who had some sentinel bleed during the acute phase, and we dilated the esophagus 4 weeks later once. And even before the patient was taken up for a second dilatation, that patient presented to the emergency with a massive bleed and died. So if there are sentinel bleeds and a CT scan suggests a very thin rim between the wall and a major vessel, I would say not to dilate that patient. Third is a very thinned out large diverticula. Yes, it can be dilated, but with great caution. You have to be very sure about what you're doing. The dilator should not buckle above the stricture, because if the dilator buckles, it's going to go through the diverticle. So these 2 or 3 things would always prevent me from dilating these patients. We've had just one patient. I don't know if the other panelists might tell us more on that. Is one patient who used to go into stridor because of the dilatation. So as soon as you start dilating, and the patient used to go into stridor. So we did that twice, and then subsequently we never dilated the patient, and that was because of stenosis on both sides. And once you're dilating the esophagus, it's compromising the already compromised tracheal lumen. So that then also forms a contraindication to future dilatations.
Harshil Shah is my student. He wants to ask you, Dr. Anurag, that for an established stricture, other than a complication or an emergency, uh, what is the definitive point for reference for surgery after you have tried either dilatation or stent?
Sir, a definitive point for surgery would be a failed dilatation. Now, here is where the definitions don't apply. So I would not go by the definition of a refractory or a recurrent stricture. I would rather go by what Dr. Brewer had to say in his study in gut, that these patients tend to go low on a dilatation protocol after 1 year. And after 3 years, it takes you 3 years for them to get to the protocol followed for a GERD stricture. So I would continue to dilate patients even if it is up to that much number of years. If the patient, one, can afford it, and second, if I am able to at least go up to 14 or 15 minimum over subsequent dilatations. If I'm just not able to go over 10, 11 after having done 5, 6, 7 dilatations, I would go on to use either intralesional steroids or mitomycin. See, mitomycin we don't use, I mean, out of habit we use steroids. And like I said, I used the electrosurgeon only once. So those would be the indications to go on to shift to a higher grade of treatment. I have personally used a stent in corrosive just once. Again, either because now less and less patients with corrosive come to private hospitals, so we don't get that many patients. And our aggressive dilatation protocol really doesn't, 10% refractory, you do get everywhere. But I don't have a very large experience of using stents, so I can just say what the literature says. But my own the experience of using a stent is just one, and the patient did very well. But yes, if the patient doesn't respond to even a stent, and you have to take that stent out after 3 months, and the patient gets into a stricture again. Rather than putting a stent again, I would send the patient for surgery. So not being able to dilate over multiple sessions, not being able to reach 13, 14, that's one thing. And second is a stent which doesn't help. That would be the end point for me.
An extension to the same question from Harshil again is that suppose we are dealing with a refractory or a recurrent stricture, and now we are waiting for, I mean, that we have decided that surgery is to be done, but we are waiting for the maturation of stricture, which I think is about 6 months, or the patient's nutritional status is poor and we are waiting for nutrition to improve. So while waiting, do we continue to dilate?
No, so I mean, if we've already decided the patient will definitely go for a surgery at the end of 6 months, and we have a feeding tube in place, I would stop dilating the patient. Why risk the perforation for such a patient and make the chances of surgery even worse? Because if you have the nutritional standby in place and you are sure about dilating, I am not very sure how one would be very sure about dilating it after, taking off the surgery after 6 months. But if yes, something in the patient tells you that you should stop dilatation, we stop dilatation. It will not serve any clinical purpose at all.
I think we finished with the online questions. Any of the experts would like to make any comment, any question to
Yeah.
each other?
In fact, a couple of technical questions with your permission, can I ask?
Yes, yes, please. Go ahead.
Yeah. So question, to Dr. Chetan. So first of all, you have advocated doing an end-to-end esophagocoloplasty. So how do you deal with the lumen mismatch between the esophagus and the colon? And secondly, again, corollary to this question, that once you are dividing the native esophagus in the neck, so how will you be able to do the surveillance of the esophagus, which is native esophagus, which is left in the body?
Right. So coming to your first question is end-to-end anastomosis. I am not advocating end-to-end anastomosis.
No. Yeah.
So in case if the lumen, there is no mismatch in the lumen, then we would like to do an end-to-end. Otherwise,
Okay.
we do side-to-side anastomosis.
Yeah, because what our practice was, again, putting the end of esophagus on the anterior or posterior wall of the colon. Yeah.
So, yes.
Yeah.
And as far as surveillance is concerned, means basically these patients, what we do is we have a good follow-up of these patients.
Okay.
So basically on symptomatology, once you feel that is when you would investigate this patient, rule out malignancy.
And you transact the esophagus in the abdomen also, or you keep the esophagus in continuity in the abdomen?
We keep the esophagus in continuity.
Yeah, because we had one patient where the esophagus was transacted. He came on follow-up and he was forming a esophagocele.
Yes.
And every 10-15 days, he will have some discharge and pleural effusion that will seal off of its own. So that problem can come, although
Right.
it is said that because of squamous lining, there will not be any secretions on the esophagus, but we can get some esophagocele kind of a thing. Because what we have been doing, we have been advocating doing a esophagectomy and gastrectomy if required in these corrosive injuries. Yeah, because we don't, because what we feel is, choosing the posterior mediastinal route is a more physiological, and you don't need to do sternotomy and dilatation because the colon goes up very easily through the posterior mediastinal route. And another interesting thing.
Let me take the student's question first before time runs
Yeah,
out.
please.
Dr. Ankit Sharma wants to know from Dr. Chetan that suppose there is a single long esophageal stricture refractory to dilatation, why not gastric conduit?
Again, because usually these patients are young, they have a huge problem of gastroesophageal reflux, which may again lead to ulcerations and a theoretical possibility of malignancy developing because of the continuous reflux. And their quality of life is greatly affected. So colonic conduit is always preferred over a gastric conduit.
Okay, Vikas, please carry on.
Yeah. Second, another interesting thing that Dr. Chetan, you have mentioned that doing a colojejunal in case the gastrectomy is required. So, but what we have been doing in our practice, particularly, is we have been doing a coloduodenal anastomosis in case gastrectomy is required, because invariably in these patients the stricture is juxtapyloric, and because of juxtapyloric and pylorus, and first part of duodenum is usually normal. and we preserve the intraperitoneal part of the duodenum, and then we do this thing coloduodenal. And when you are using jejunum, you are using it as a loop jejunal loop anastomosis, or you making a separate Roux-en-Y loop?
Separate Roux-en-Y.
Separate. So that means you are adding one more anastomosis.
One more
to the, yeah.
Yes.
Yeah.
So, Chetan, suppose we are using right colon, will it be a esophagocolic anastomosis or will it be an esophagoileal anastomosis preserving the ileocecal valve?
So basically,
mentioned.
So we are generally using left-sided. Very rarely we have used a right-sided, but in that case, it becomes a esophagoileal. A small portion of the ileum is kept behind, so the advantage of the ileocecal valve is maintained.
Yes.
Yeah,
And
we have 4 more minutes. Yes.
Yeah, please. Okay. And another interesting query, I mean, when you are using left colon based on ascending branch of left colic artery, and you are using isoperistaltic or you are using antiperistaltic loop
So
colon?
we use isoperistaltic.
Yeah,
Having said that, actually it's a conduit. It doesn't matter whether you use isoperistaltic or antiperistaltic.
No, that is okay, but because there are two ways of doing it. Because based on the ascending branch, you can take the descending colon and sigmoid in the neck. Another way is to take the transverse colon and ascending colon in the neck. So that becomes iso and anti. That is what my contention was asking. So because what we have been using is taking the transverse colon and ascending colon in the neck, basing on the ascending branch of left colic artery.
So you all use the right side.
Yeah, we will use transverse colon and the
ascending colon.
Yes. Okay.
Any other? Yes, Das. Any specific points?
I have 2 questions, but first I will start with Dr. Anurag. How long we go on? This is a question put to me by my students many times in the rounds. How far and how long we go on dilating these people?
So
What is the longest follow-up that we are having? Patient surviving on dilatation only.
If I am allowed to quote my DM days, then we've had patients coming for at least 7-8 years for dilatation. But here, as of now, I still have one patient who's been coming to me beyond 2 years for dilatation. What happens is, I mean, my own cutoff would be not being able to go up to 14 also. So if I can go up to 14 millimeters, I tell my patients that you have to now come back as soon as you get the first sign of dysphagia so that I can start dilating you all over again early. But if I'm not able to go up to 14, I would not go on for years together.
So are there cases who are going on dilating for last 20 years, 30 years, because they're adolescent and adults. They will live for 40 or more than maybe up to 60, 70 years. So how long we can go on dilating? Is there any really long-term study to say that after 30 years also with dilatation, they can survive and have a good quality of life?
I cannot quote a study, sir, but all I can say is that uh, can you hear me?
Yes, sir. Yes, sir.
All I can say is that if there is a patient who comes back to you maybe at 15 years or 20 years with a fair interval of no dilatation, there would be no reason not to dilate this patient. So, but I can't quote you, I cannot give you hard data to support what I'm trying to say.
Okay, but if we believe Dr. Nishaat, then we should not be dilating any one of them.
After 20 years of that, so you have to do.
There is a definite risk of malignancy.
Yes, sir. I mean, one has to obviously screen them and screen them well. I mean, we don't follow a screening protocol, at least here in India, because they don't come back. I mean, if we go by the literature there, we have to start screening after 15 years of the corrosive intake and keep doing it.
Exactly. I was going to ask that screening protocol.
Yeah, so screening protocol would be after 15 years of corrosive, it starts after 15 years and every 2 to 3 years. But I don't think I've ever done it in any patient. I mean, they don't come back. And but yes, if they come back after a long period of no dysphagia, first thing to do would be, of course, to rule out a malignancy. And if you can rule out a malignancy with high definition scopes with NBI, and taking directed biopsies, you can be reasonably certain that you're not missing out on an early malignancy. But yes, if you're not certain on missing out on an early malignancy, then of course it will not be. That will be the end of dilatation and surgery.
So we have
And
9
last but not the
minutes.
least, sir,
Any concluding remarks from Das and Vikas? We have to finish.
So
soon.
before that, interestingly, I think I guess Dr. Ankit Sharma, who is asking questions time and again about the gastric pull-up, is one of our MCA students. I think he is asking that because he is seeing us doing gastric pull-up in many cases wherein the cervical esophagus is fine. What I used to do is after dividing the esophagus down below at the G junction, I make a small hole. We need to do pyloric stretching. At the same time, I do a scopy and see what is the mucosa status of the stomach. It looks reasonably well. I lift up the stomach. Now, regarding the reflux part, it's well described in the literature. You can cover these people. They're not always having reflux all the time. It is just like you do a coloduodenostomy. We did four cases of coloduodenostomy. All of them had refluxes. Unfortunately, I don't know why. And then we have to change to colojejunar anastomosis 1Y. Similarly, we have never seen very really troublesome refluxes in these patients who have stomach pull-up. But at least when you do a stomach pull-up, we are sure that we have a backup. If that gets strictured, we have a colon to deal with. And same thing, we also we need to discuss some point of other sometime that what happens to the restrictures. That should be that was my last question. What happens to the restrictures? We got not enough literature on this. So Dr. Chetan, if you can conclude by saying that.
So as far as restrictures are concerned, we keep these patients on regular follow-up post-surgery. And we do their periodic endoscopic and confirm that it remains patent. Another important thing I wanted to point it out, especially to Dr. Govil, is what we do is following a successful endoscopic dilatation, we teach this patient self-buginage. And we ask them to do that at home and come to us periodically at the end of 3 months initially, then 6 months. And that is how we ensure that they remain dilated.
Sure, that's right, sir.
I think we need to, because we are already 3 minutes beyond 9. We follow strictly starting at 7 and finishing at 9. So I must thank Das and Vikas, who very readily agreed to moderate this session. Thanks to all the speakers, Dr. Anurag, Dr. Chetan, and yesterday's speakers. But special thanks to Nishaat and Harindra, who are the young faculty for the masterclass so far. I have been approaching all the senior colleagues, but this time I thought I will ask young faculty also to come in, because this is how they will get trained in making presentations. And I hope they don't mind if we make them some comments and some suggestions, of course, privately, not in public. And thank you. And I must add that all the technical support for all the activities of JST and master classes and Jaipur Surgical Festival are provided by Dwarika Clinic, which is owned by my former fellow from SGPGI, Dr. Avinash Tank, and his team, Himanshi and Pinesh. Himanshi, if you are there, would you like to come in?
Yes, sir.
Put your video also on camera if you want, if you can, so that everyone can see you. And we would like to thank you and Pinesh for all your help. Oh, both of you are there. Good, good. Thank you. Thank you very much. Thank you. Thank you. Thank you, everyone. Good night.
Thank you, sir.
And we will have the next masterclass on the last week of January. Thank you.
Thank you very much.
Thank you, sir. Thank you, sir.
Thank you, sir.
Thank you very much.
Thank you.